Hello, everybody. It's Professor Al-Hazza again. Now we are going to be starting our series of the 5 lectures. This is the first lecture of the 5 series. I'm hoping that my orientation and instrumentation was of help to each and every one of you, simply because I sort of introduced you to ophthalmology, and I oriented you and showed you a little of the important instruments that you don't need to know how to use except the ophthalmoscope, but at least know what they are by name. So our first lecture is going to be on visual impairment. As you know, as an ophthalmologist, we do examine the vision. And so I will be talking to you about the visual impairment. There are many definitions. This is the definition that is the most comprehensive, and for you as second year medical students. So when we say total blindness, it simply means the patient is unable to tell light from dark. I mean, you shine the brightest light into their eye and they will not be able to know if there is a light or not. This is what we refer to as total blindness. Then we go to what we call visual impairment or low vision, and simply it's just a reduction in vision that cannot be corrected with the standard glasses or contact lenses, and it really reduces a person's ability to function at certain or all tasks. So it depends. It can be anywhere. The normal, as we mentioned in our orientation and in lecture, that it's either 20/20 or 6/6. These patients will be below that. So they can be 20/20/30, they can be 20/50, 20/60, and 20/70. So the larger the denominator is, the worse vision it is. I'd like you, again, because this is optics and I want to teach you ophthalmology rather than optics, please read on the visual acuity and the differences between 20/20 till we reach what we refer to as legal blindness, as you see here. This is what we refer to as 20/200. And this is severe visual impairment. So when a patient can only see the 20/200 letter, unfortunately, he is considered legally blind. And in many parts of the world, he's entitled to financial help as he is considered legally blind. Another way to also define legal blindness is with the visual field. Usually our visual field should be large. So, and you should, even though you're looking straight ahead and you put your hands to the side and you're looking straight ahead, you should be able to see your fingers moving. This is what we refer to as the visual field. And these patients who are legally blind, their visual field is no greater than 20 degrees, which is really almost like looking through a tunnel. Like you get a piece of paper, you roll it, and you're looking through it. So all you're seeing is your central vision and no peripheral vision. Let's talk a little about the visual pathway. The visual pathway really starts with the cornea. That's when the vision first hits the visual pathway. And then you have your anterior chamber. And I mentioned to you before, this is where your aqueous humor is produced by the ciliary body. It's produced by the ciliary body and actually circulates in the anterior chamber and what we refer to as the posterior chamber, which is between the iris and lens. Then you have your iris, which is your colored part. Between the two irises is the pupil. Then you have your lens, which is the crystalline lens. Really important. It's actually suspended in the eye, if you will, by the suspensory ligaments, as you see there. Then you have your vitreous. This is the gel part that's in the back, what we refer to as the posterior pole. Then, of course, you have your retina. So that's your vitreous. Then you have your retina. Then, of course, you have your choroid, and then you have your sclera, but they are not part of the visual pathway. And let's go back again. And then this is your actual here macula. So it starts from the cornea and ends at the macula. If we take a close-up, as you can see, this is your retinal ganglion cells. Please read on them. It's your phototransduction. It's what you have is your rods and cones, as you see. And then there's the imaging processing by your horizontal, bipolar, amacrine, and your retinal ganglion cells. And then you have your output, of course, which we're going to be talking more about, to your optic nerve via the retinal ganglion cells and the nerve fiber layers. So all these are your nerve fiber layers, and they go into your optic nerve, or first optic disc, and then your optic nerve. Again, please read this on your own, as I'd like to concentrate on the clinical part as an ophthalmologist, and you should be able to read this, this in details within your books, please. So there's your visual pathway. Now, when we talk about the visual pathway, as we mentioned, we have what we refer to as the retina. From the retina, it goes to the optic disc. From the disc, it goes to your optic nerve. Then, of course, they decussate at the optic chiasm, very important. From your optic chiasm, it goes to your lateral geniculate nucleus, which is in the thalamus, and then into your primary visual cortex. Now, if you would have a lesion in any of these pathways, whether at the optic nerve, whether at the optic chiasm, whether at your lateral, in your optic tract, or in your lateral geniculate nucleus, which is your thalamus, or in your occipital lobe, you get certain visual pathway lesions. And I'd like you also to please go into that and study it further, as I mentioned, and hopefully we'll be covering that in the lectures to come. So that just shows your pathway. That was your visual pathway that starts from top and goes all the way ending into the occipital lobe. So we're going to be talking about the visual impairment. We're going to be talking about acute visual loss. I'm going to be covering acute glaucoma, central retinal artery occlusion, central retinal vein occlusion. I've missed the R here, my apologies. Retinal detachment, optic neuritis, cortical blindness, and functional disorders. And then we're going to be talking about the chronic visual loss, and we're going to be talking about it later. So let's concentrate now on the acute visual loss. It's a loss of vision. It's acute, it's sudden, and it can develop within a few minutes to a couple of days. That's what we refer to as acute visual loss. It can affect one or both eyes and all or part of a field of vision. So when we talk about acute visual loss, it can be due to media opacities, it can be due to retinal diseases, it can be due to optic nerve diseases, visual pathway disorders, functional disorders, or acute recovery of a chronic visual loss, and we'll be covering that. So when you're acute visual loss, you have your media opacities, you have your acute glaucoma, very different from the chronic, which we'll differentiate, your central retinal artery occlusion, your central retinal vein occlusion, your retinal detachment, optic neuritis, cortical blindness, and functional disorders. I'm going to be going through this, and interestingly, a lot of what I will be covering in the visual impairment will overlap with the systemic diseases. So I'm going to be covering it more here, as this is your first lecture, and then simply allude to it when I'm doing your systemic lecture. So when you have someone that presents with an acute visual loss, history is essential. It is very important, the history. So you ask yourself, is the visual loss transient? Did it happen? Or is it persistent? Did it just come and go? Or is it persistent? Is it one eye or two eyes? Did it occur suddenly? Or was it over hours, days, and weeks? Very important to take the patient's age. The patient's general condition is also very important, even though it's the eye. But you have to remember the eye is part of the body. So the general medical condition. And then you ask the patient, did you have normal vision in the past? Because you have to rule out what we refer to as amblyopia and lazy eye, which I will be talking to you in the strabismus lecture. And then, really important, is ask your patient, when was your vision last tested? When did you last go to an ophthalmologist and have your visual acuity tested? These are really very important in the history. Then, of course, we do our tests. Now, as you see here, we have 5 tests. All of them are important. Visual acuity testing you have to do, confrontation visual fields, pupillary reactions, ophthalmoscopy, which I talked about, external examination of the eye with a pin light, and your tonometry to measure the intraocular pressure. Now, out of all these 6 tests, when you come to the 5th level, as a 5th year medical student, the only 2 you will have to know how to do is your confrontation visual fields and your ophthalmoscope. You have to be able to master these 2. Visual acuity testing, pupillary reactions, you do have to know them, but not master them. External examination with the pen light and tonometry. These are usually done either by the ophthalmic technician or your nurse or the resident. For you as a non-ophthalmic resident, you do have to know how to do the confrontation visual fields and your ophthalmoscopy. So let's first start with the media opacities. Your first media opacity, remember we talked about your watch in the what I call the pre-lecture, in your orientation, and as we mentioned, your the glass part is your cornea, the clear part. You can't see it, but you can feel it and you know it's there. This is what we refer to as the cornea. Many a times the cornea should be clear, as we see in this nice of eye of this child. With it, because it's clear, I can see the pupil and I can see the iris. Unfortunately, when you get corneal edema, as you see in this patient, or corneal opacity, you cannot see the details of the iris and you cannot see the details of the pupil. So the cornea, if you look here, it really looks like a ground glass. It is not a clear appearance. And when do you get this? Increased intraocular pressure. Unfortunately, in children, we call it congenital glaucoma. You also get an angle closure glaucoma, what we refer to as acute glaucoma, or corneal ulcer in acute infections. Other media opacities, you can have a hyphema. When we say hyphema, we simply mean blood in the anterior chamber. I think you can see it here. We refer to what the anterior chamber is. The anterior chamber is the chamber between the cornea, which you cannot see, and the iris, which is the colored part. Look at your watch again, that space between your glass part and where your actual numbers are. So it's blood in the anterior chamber, and you can see it here. Thank God it's not covering the pupil, but here, unfortunately, this is covering the visual axis. Remember, we talked about it. It goes from the cornea through the pupil, through the lens, and here it's covering it. So this patient definitely will have acute visual loss. The causes are blunt trauma, tumors, diabetes, intraocular surgeries, chronic inflammation, and blood dyscrasias. Another important media opacity is the vitreous. Remember, we talked about it's the cornea. You have your anterior chamber. your pupil, your lens, this is where your visual pathway, and then you have your vitreous, which is the gel part. Please read on it. This is when you can get a vitreous hemorrhage. This is really very unfortunate. And here you cannot see. Remember before in the orientation, I showed you the nice optic disc and the nice macula. Here, unfortunately, you cannot see it simply because of the media opacity of the vitreous. It is not clear. Causes are trauma, diabetics. I'm going to be talking to you a lot about diabetes in both this lecture and in the systemic retinal vein occlusions, subarachnoid hemorrhages. This is very unfortunate, and certain blood dyscrasias. So now let's talk about the aqueous humor outflow. This is really very important. This is what I told you. It circulates. This is your cornea. This is your iris. This is your anterior chamber. It's actually produced, the aqueous humor is produced by the ciliary body. It circulates, moving from the posterior chamber through the pupil. Remember, between the pupil and the lens, there is an opening. This is where you see your pupil. So it circulates from the posterior chamber through your pupil, as you see nicely here, into the anterior chamber. And then the outflow is the trabecular meshwork in the angle, as you see nicely here. This is your trabecular meshwork. And then it goes out through your uveal scleral outflow. So when we talk about acute glaucoma, this is an acute visual loss. Remember, we talked about the normal pressure is 10 to 20. These patients will present with 60 millimeters of mercury pressure, which is considered highly elevated. So unfortunately, they will have severe visual loss to optic nerve damage. I showed you before the nice optic disc. This is a very large optic disc. I would go to 0.8 to 0.9. What we're saying is the optic disc, unfortunately, is when you compare it to the optic cup, when you compare it to the optic disc, the optic cup takes a large amount. This is why we refer to it as 0.8, which you don't have to worry about. The only way I can examine the patients is usually through a table-mounted slit lamp. They are portable for patients that are bedridden, but to do a proper exam, it would be nice to use the table mounted. And then, of course, there is severe visual loss due to the optic nerve damage. And usually, the way we treat these patients is simply by doing a hole in the iris, simply to release the aqueous humor through another channel, and therefore your intraocular pressure is then totally decreased back to normal. So what is usually your presentation? Severe painful red eye, redness, mid-dilated pupil, decreased vision, colored halos around the lights, severe headache, nausea, vomiting, and a cloudy cornea, as you see very nicely here. The cornea is very clouded. It is not clear, and you can see the pupil here is not nice and small. It's actually mid-dilated, and look at all this redness. That is really unfortunate. Another visual impairment or acute visual loss is the retinal diseases. We finished from the opacities, the media opacities. Now we'll come to the retinal diseases. An important retinal disease is a retinal detachment. You don't really have to know much more than when you do. It is a sudden but painless loss of vision, but it is acute. You actually have a hole, as you can see nicely here in the periphery of this is, remember, we talked about the optic disc. We talked about the macula. This is just showing the periphery. This is usually where these retinal detachments occur. And unfortunately, patients will see flashing lights, floaters. So if a patient comes to you, even if you're not an ophthalmologist or your relative, they complain about flashing lights or floaters or a blind covering the visual field, please direct them immediately to the emergency room. They usually will have an afferent pupillary defect. I'd like you to please read on that. This is part of your, and now we're going to be teaching it to you more when you come to the 5th grade medical student. And unfortunately, both the peripheral and or central visual loss, and it is considered an emergency. And here you see the whole retina detached, unfortunately. Another important retinal diseases is retinal vascular occlusions. So the central retinal vein occlusion, this is actually severe and it's sudden, but it is not really considered an ophthalmic emergency because once it happens, there's other ways to management. So it is not an acute management, but it is considered an acute visual loss. So this is your retinal vein occlusion. This is your retina. So here you can have it as a branch, but we're concentrating on the central retinal vein occlusion. So what you get is you get, unfortunately, a dilated tortuous vessels, as you see here. And this is really unfortunate. You get cotton wool spots. We're going to be talking more about that. Please read on it before our next lecture. You get a macular edema simply because there's so much fluid that's accumulated. Look at your optic disc. You can no longer really see the edges of it. So we refer to it as optic disc edema. Look at this venous engorgement. This is what I refer to as a very angry retina. And then, of course, you get your retinal hemorrhages, as you can see very nicely here. We call it blood and thunder. Another acute visual loss is under retinal vascular occlusion is what we refer to as a central retinal artery occlusion. This is the flow of the blood in the central retinal artery is blocked, as you can see very nicely here, with a plaque. It's occluded, and this is usually due to carotid artery atherosclerosis. This is your normal carotid artery, and this is your blocked, and unfortunately, it dislodges into the central retinal artery, causing central retinal artery occlusion. And I will tell you, this is a really very important exam question. You're usually asked all the time about central retinal artery occlusion. Unfortunately, the most important is you do get what we refer to as the cherry red spot. And I think you can see it very nicely here. The cherry red spot, you get ischemic retinal edema and whitening, as you can see here, very different from your central retinal vein occlusion, which was thunder. And you get your retinal embolus, and you get a shiny cholesterol gray and white calcium plaques. This is what this is actually pointing to. Another important acute visual loss is optic nerve diseases. We refer to as optic neuritis. I'm going to be covering this, a lot of the diseases in the systemic. The optic neuritis, when we say optic neuritis, it's simply from the optic nerve, but we say neuritis. It's an inflammation of the optic nerve. Anything that ends with itis is inflammation. And you can see that in multiple sclerosis. We're going to be talking about that in the systemic. An afferent pupillary defect is definitely present in this optic neuritis. You get a hyperemic and swollen disc. As you can see, I don't know where the borders are. The visual acuity usually recovers, which is good. But the repeated episodes, if you keep getting it over and over again, it can cause permanent loss of vision. So here's your visual pathway disorders, your acute visual loss. As we see here, it is really unfortunate. This is your optic, if you will. This is your optic nerve. And usually what you get in that, so lesions of the optic nerve, you get ipsilateral monocular visual loss. And this is the visual field picture that you get. I'm really making your life easy here and giving it to you nicely. And then lesions at the optic chiasm, as you can see right here. you get what we refer to as a bitemporal hemianopia, nicely depicted here. And then you get lesions of the optic tract. So you finish your optic chiasm. Remember the optic chiasm, this is where you have the decussation. This is why both sides, both eyes are being affected simply because of the decussation. And then when you get lesions of the optic tract, what we refer to as a homonymous hemanopia, this is what you're seeing here. And then your next is your parietal upper optic radiation. So you get what we refer to as inferior quadranotopia. I like to call it a pie in the floor. This is what I refer to it as. So if you don't want to have a lot of big names, you can call it pie in the floor. And then your next would be your lower, your temporal lower optic radiation. Before it was the parietal, which caused the pie in the floor, if you want to remember it. Parietal, pie in the floor, or it can be your temporal lower optic radiation. This also causes a superior quadranotopia, and this is what I call a pie in the sky. And then last but not least is your lesions in your occipital visual cortex, which we refer to as macular sparing. Please understand these. I don't want you just to memorize them. Please understand them because you will need them not as ophthalmologist, but you will need them as a general practitioner, neurologist, and so forth. So this is your visual pathway disorders. I hope I have made it easy for you. Then we have something called acute visual loss, which is a cortical blindness. And this is really very unfortunate because as ophthalmologists, there's not much we can do. It's actually damage to the cerebral visual pathways. It's rare, but it's extensive, and it can be cortical, central, or cerebral blindness. Usually the pupillary actions are normal, and when we examine the fundus, it's normal. This is why we call it cortical blindness. I also like to call it higher. So the patient cannot see and be blind, but it has nothing to do with the eye. It has to do with the visual cortex. Then, of course, last but not least, we have what we call the functional disorders. And this is when a patient malingers, pretends not to be able to see simply without any organic basis. It can be due to hysteria or maybe trying to have some financial gain. And they will usually report complete blindness in one eye and normal vision in the other. There is no afferent papillary defect. And as ophthalmologists, we can usually figure them out with certain tests where we actually try to deceive them, if you will, until we can find out the real visual acuity. Okay, so now we've covered the acute visual loss. Let us now go to the chronic visual loss. We're going to talk about the chronic glaucoma, very different from the acute glaucoma. I told you the acute glaucoma, they come in, they're in pain. Many a times with the acute glaucoma, they can be diagnosed as an acute abdomen, and many patients with acute glaucoma have had their appendix removed because they think it's an appendicitis. We're going to be talking more about that when you come to the 5th year. So now in the chronic visual loss, we're going to be talking about chronic glaucoma, cataract, macular degeneration, and diabetic retinopathy. So the chronic visual loss, it's slowly progressive visual loss. It's important to measure the intraocular pressure, evaluate the nerve head, evaluate the clarity of the lens, and also evaluate the function and appearance of the macula. So under chronic visual loss, we talked about the types of glaucoma. We talked about the acute glaucoma. We're going to be now talking about the chronic glaucoma. I'm not going to be covering the congenital glaucoma until you come to the 5th year. So regarding the chronic glaucoma, they call it the silent thief of sight because it really steals your sight, and it does it silently. And it's so interesting that in the Arabic, for those of you that speak Arabic, they call it a swearig. Patient will come to you and you'll ask him, since when have you had your loss of vision? He'll say, I have a swearig. Swearig means the thief of sight. Usually there's an elevated pressure in the eye. Unfortunately, it is asymptomatic, so patients can lose a great part of their vision without even knowing. It's usually detected on routine examinations. There are many risk factors, as you read there. There's an impaired drainage of the aqueous humor through the trabecular meshwork, and it can be due to age-related morphological changes. So I encourage each and every one of you to have your parents, because I'm sure they're above 40 years of age, to have their intraocular pressure measured. It is very common in the Arab population, very common in the underdeveloped population. So please take your parents after this epidemic we have, and make sure that they do get their visual, their intraocular pressure measured. If the intraocular pressure is above the normal, we say 10 to 20. I like for your parents to say 18. For your exam, it's 10 to 20. And if it's above that, please take them to an ophthalmologist for further management and possible treatment. So here's your this is your normal. Remember, we said you have your cornea. Your cornea is the crystal part. You have your anterior chamber. You have your iris. You have your lens. Your ciliary body produces your aqueous humor. It goes through the posterior chamber, which is between the iris and lens, goes through the opening between the iris and lens, then goes into your anterior chamber, and then out through the trabecular meshwork. In chronic glaucoma, unfortunately, things can be pushed forward. You can get, even though here I wrote a closed angle, it can be both closed and open angle. And unfortunately, everything is pushed forward. And this is the essence of your closed angle glaucoma, but also can apply to your open angle if there is no pushment forward. I just showed you this to be able to understand it. It's the second most important cause of blindness in this part of the world. It's the good thing about it, it's preventable if detected early and treated. The peripheral vision loss is really, you lose your peripheral vision before you lose your central vision. So patients, because it's done gradually, they don't really know that they're losing their peripheral vision slowly and slowly and slowly, because we tend to concentrate on our central vision. The routine measurement of the intraocular pressure is essential. It's from 10 to 20, and the elevation of the intraocular pressure can lead to optic nerve damage. So our management is to stop the progress. You cannot recover sight that has already been lost. That's why it's important to get your parents and relatives over 40 to be examined. Whatever you lose, we cannot restore it. All we can do is halt it. So I always tell the patients that come to me, whatever medication I'm giving you, whatever surgery I'm giving you, it is not to restore back, because once you damage your nerve fibers and it affects your optic disc and optic nerve, unfortunately, you cannot restore it back. We do have medical treatment, which is reduction of the aqueous secretion, or more or less medical treatment. And then we have surgical, which would be lasers. That's all you need to know. And filtering surgery. And the filtering surgery is just we make a bleb where we can have more of the aqueous humor out. So another chronic visual loss is cataract. Remember, we talked about, I showed you a very nice lens that was not cataractus. This, unfortunately, is opacity of the lens. The symptoms, again, are gradual, so patients do not really know, because they have two eyes. They might just depend on one eye, and then one day they might cover the good eye and say, oh my God, I have sudden loss of vision. This is not true. It's a gradual, and it's a reduction in your visual acuity. Unfortunately, you lose your contrast sensitivity in low light, and there's glare in the bright lights. A lot of the cataract patients will tell you, I cannot drive at night because of the glare. And the pathophysiology, it's a progressive opacity. You have loss of organization of your proteins in the lens. The symptoms are due to blockage, aberrant refraction, or forward reflection of the light. I showed it to you very nicely when I showed you the visual pathway. Your visual pathway, your lens is a very important part. And you can see here, this is not clear. This is what we refer to as cortical spokes of the cataract. Again, it's really mainly age-related. This is the most common cause. There's many multifactorial, just read diabetes, hypertension, obesity, so forth. The ocular, high myopia and uveitis, steroids, trauma. There are certain syndromes, and unfortunately, intrauterine infections can, whether rubella or toxoplasmosis, cytomegalovirus, can cause this in the infant and the fetus even before he is born. And here I'm just showing you, this is your cornea, this is your anterior chamber here, and this is your lens. And you can see that the lens is opacified. And the only way to treat a lens opacity, no matter what you hear, is through cataract surgery. It's done through a ultrasonic, people refer to it as laser, which can be referred to, but it is cataract surgery, whether through ultrasonic laser, and then we go in and we put in because we remove the lens, we put in an intraocular lens, which is the artificial lens. Let's now spend a couple of minutes. I want to tell you what the macula is, even though I did explain it to you in the pre-lecture, in the orientation. But here is, remember we talked about the optic disc. This is your macula. Because this is the right eye, your macula is always temporal, if you will, to your optic disc. These are your blood vessels, and smack in the macula is your fovea. Really important. So if you look here, again, let me go over it again. This is your cornea, your crystal part, your anterior chamber, your iris, which is the colored part. Then you have your pupil. Behind the pupil immediately sits the lens, which should be crystalline clear. Then you have your posterior pole. Here is your macula. So this here is this here. Here is your fovea, that is the central of your vision. This is where it gives you the 20/20 vision. Then, of course, you have your blood vessels, and then you have your optic disc, which goes back to the optic nerve here. These are your 11 layers of your retina. Please read through them. It's really, I think it's of importance to know them. This I show here, which is really interesting, and this only, I wish we had what we refer to as the OCT, optical coherence tomography. If you think of the brain, when we do the MRIs or the CT scan, we take slices of the brain. This is actually taking slices of the retina. So this would be your nerve fiber layer and your internal limiting membrane. This dip right here is your macula. In the center is your fovea, and this is, of course, devoid of rods. Again, you should know the rods are in charge of the night vision. They're in the periphery. The cones are your central vision, and they are in the center. Now let's talk a little about diabetic retinopathy. This is also one of your chronic visual loss. Diabetic retinopathy, unfortunately, here in the kingdom, the Gulf area, and the Arab countries, we are the #1 in obesity worldwide, and the #1 side effect of obesity is, unfortunately, diabetes. And when you develop diabetes, you get, which is of importance to me as an ophthalmologist, your diabetic retinopathy. Let's talk a little about it. In diabetic retinopathy, unfortunately, you have your microvascular occlusion, as you see it here. You have your thickened capillary basement. You have your thickened capillary basement membrane. You have then your capillary endothelial cell damage. Then you have changes in your RBC. Then that's when you develop your retinal ischemia. And because you have your retinal ischemia, unfortunately, you get what we refer to as AV shunts. You can see them here, your AV shunts. And then unfortunately, you get your neovascularization, which is your vasoproliferative substance. And this is where I have this green, is your neovascularization. Once you have your neovascularization, unfortunately, the patient is going to be going blind if he doesn't get his exam, ophthalmological exam, by a retinologist who is experienced to be able to identify it and treat it before losing vision. So this is your microvascular occlusion. Then we have what we refer to as microvascular leakage. You lose your parasite cells between the endothelial cells. Then you get leakage of plasma. You see all this edema here. This leakage of plasma in the retina is referred to as, and you're going to be seeing, as hard exudates. This is your hard exudate. It comes simply because of leakage, and you see your hard exudates very nicely here in this retina. This is your macula. So unfortunately, they have caused macular edema, which unfortunately is an important component of vision loss in diabetic retinopathy. So the diabetic retinopathy, you have types: non-proliferative, proliferative, macular edema, and end stage. All I need you to know is simply if we go back to the first, here there is, in this one here, there is no proliferation. So we refer to this, because of exudate, we refer to this as non-proliferative diabetic retinopathy. Here we do have proliferation, and I told you why. Because of the neovascularization, this we refer to as proliferative diabetic retinopathy. And then, of course, your macular edema, I showed you, and then end stage, this is when they go totally blind. So just showing you a couple of proliferative. Here's your neovascularization of the disc, proliferation, again, proliferation, proliferation. Then unfortunately now, because the proliferation was not treated, you started getting your hemorrhages, and these patients will go blind. So the clinical classification of diabetic retinopathy is really very simple. Here, there is no proliferation, so we just call it non-proliferative diabetic retinopathy. Once you get your proliferation, as you see here, I showed you nice examples of neovascularization, we call it proliferative retinopathy. End of story. Very simple. Non-proliferative and proliferative. You don't really need to know anything other than that. The treatment for both, whether non-proliferative or proliferative, is laser. Laser simply means light amplification stimulated emission of radiation. So we do either, if it's just non-proliferative, we do the laser here around the macula. If it's proliferative, we do it all, the whole retina away from the macula. Now, let's talk a little, if I can go back, also another mode of treatment, I didn't really want to go into it, is anti-VEGF. I'm sure you're going to be hearing lots about it when you come to your 5th year, and God forbid, we might have to even revert to surgery. Macular degeneration, this is a chronic visual loss. This macular degeneration, unfortunately, it's a leading cause of irreversible central vision loss, 2200 or worse, over the age of 60, but not in our part of the world. It's mainly in the developed part of the world. So we see it, but not as much as we do in the outside or in the West. It impacts millions of older adults every year. This is mainly in the US and Europe. It affects the central vision. So when a patient with macular degeneration looks at you, this is what they see. They can see your periphery, but they cannot see the central. When looking here, there's always a central blind spot. So for them to be able to see your face, they will have to turn to the right or to the left to move this blind spot. They have difficulty in reading, driving, or even performing other activities requiring fine, detailed vision. It's usually what's affected is usually the central vision, so they can usually navigate. The peripheral vision is usually preserved. It's multifactorial, so age, the older you are, the worse it is, smoking, vascular disease, UV light, diet, and family history. And they usually refer to it as atrophic or exudative, which I don't expect you to know. It's enough to know that one of your chronic visual loss is macular degeneration. And this is, remember we talked about exudates? So exudates, I'm going to be talking to you more about it in the 5th year. Exudates is part of your micro leakage. So this is part of your non-proliferative diabetic retinopathy. In macular degeneration, it's drusen. very different from exudate. So they're small, they're discrete, irregular shapes. As you see them, they have indistinct edges. They can be colloidal bodies, and they're deposited in the Brooks membrane. So they're more towards the choroid, whereas the exudates are in the retina. So again, I just show you this macular degeneration. Unfortunately, these are all drusen. This is your normal OCT. Remember I showed you when you have this abnormality, this is what your OCT looks like. So you have a lot of degeneration and even macular edema. The management, you can either observe them, laser photocoagulation, PDT, or anti-VEGF. And by the way, the reason I didn't write it is this anti-VEGF is also used for diabetic retinopathy. So I would like to thank you all for your attention. I hope that we have covered most of the visual impairment. As second-year students, I only wanted you to have the basis of visual impairment, and our following lectures will also show you, we'll be tapping on certain visual impairments within the various lectures. So we finished now the visual impairment, and we should now be going to our following lectures in due time. Thank you all very much for your attention.